Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. We're here in Berlin, ESMO 2025. It's been a great a GU meeting, a lot of great data, and now we're talking prostate cancer.
Yeah, lots. I mean, another presidential in GU for prostate, we'll cover that. But clearly, why don't we start earlier and go by disease trajectory? Let's start with the so-called localized setting. We saw data in the so-called high-risk localized with ENZARAD, and then we also saw data for biochemical recurrence, an update of enzalutamide in that space. So Chris, why don't you take us through those?
Absolutely. I think, the general trajectory in oncology is always to establish the drug in the later disease phases and then try and test it earlier on. And ENZARAD is the natural continuation of, I think, our current understanding of using ARPIs in prostate cancer. So to lay it out, ENZARAD enrolled NCCN high-risk patients. So that's clinical 3, high-grade histology, Gleason 8, 9, or 10, or PSAs over 20. That contrasts a little bit with STAMPEDE, which was an enriched, very high-risk population, i.e. clinical node positive, or 2 out of the 3 of PSAs over 40, Gleason score 8, 9, 10, and clinical stage T3. So this is a NCCN high-risk population, but a little less high-risk than STAMPEDE. And in the context of ENZARAD, patients were randomized to either a control arm that included radiotherapy in very modern and appropriate doses and delivery approaches, and 2 years of ADT, and then the intervention arm got that as well as the addition of enzalutamide. And I think it's important to note back to the demographics to understand that this cohort included about 10% clinical node positivity, in contrast to STAMPEDE, around 40% clinical node positivity. So we are looking at a high-risk patient population in the localized disease setting, but a little less high risk than the data we've seen before. As we move forward, we're looking at a primary endpoint of MFS. That's the appropriate thing, I think, in this context. IceCap shows us surrogacy. So if we can improve MFS, we are almost certainly improving OS. Unfortunately, in this trial, we don't improve MFS. We have a hazard ratio of 0.88. We have, at baseline, just really good outcomes, I think, for our patients in the control arm. And so, when your 8-year MFS is in the low 70, 72%, it's a bit hard to improve on. And so the intervention arm got to 74%. But I think that tells us that our current standards of care are actually performing quite well. We see OS data, which again, not shockingly, not significant given the lack of MFS benefit. And I think, this leaves us in the position where we have to try and tease out and understand maybe within ENZARAD how the overlap between ENZARAD and STAMPEDE non-metastatic exists, to help us sort of tease out the role of ARPIs a little better in this disease space.
Yeah, so it struck me that, and again, kudos to the team for pulling this off. These are important data to ensure that, we see some signals across this localized setting. It's a lot of patients around the world. So 2 things, Chris. One, is it as simple as saying, if you looked at the STAMPEDE type population, at least the node positive, we'd get a signal of possible benefit? And if true, I was struck by the discussions at the end that basically felt that if they had a STAMPEDE type patient in their clinic, they see no reason why they couldn't use enzalutamide along with, separately, but as another option in the toolbox as AbbVie. So STAMPEDE population and ENZARAD, and then do you think these pills could both be used in those situations?
Yeah, so there's 2 ways to break out the STAMPEDE population. There's the clinical node positive, and then there's the clinical node negative, but otherwise STAMPEDE eligible. That second subset's easier to hit first, which is to say that didn't really benefit. But in the ENZARAD population, the group that seemed to get the benefit from the addition of enzalutamide was clinical node positive. And so there we saw a hazard ratio of like 0.4 for the addition of enzalutamide. That's very consistent with the benefit of adding AbbVie in the context of STAMPEDE, a very comparable MFS benefit. And so I do think that in the clinical node positive patient population, we do see, I would say, consistent evidence now that adding an ARPI is of clinical benefit. The real question, is thinking about how we contextualize this. So in Canada, we're not going to get strict reimbursement probably to use enzalutamide, defining patients like this. And the complicated part, of course, is that this is a conventional imaging trial in the same way that STAMPEDE is a conventional imaging trial. And so if we think about, conventional imaging node positive, if you're doing a PSMA PET, these are almost certainly polymetastatic patients. And so, we can justify in that M1 space the use of ARPIs, and you could bring enzalutamide onto the table there. And I think the real incremental gain here, if you're thinking in that way, is that we can think now about fixed durations of therapy rather than committing PSMA-defined metastatic disease to lifelong ARPI. We can think about using, fixed durations and giving patients an end date for their ARPI.
Let's get back to that, because I think the next abstract kind of helps us put a through line to what we're going to talk about to wrap up the localized space. So take us through the update of OS for ENZA and the so-called biochemical recurrent. And then I think we should come back to what we really will take away, rather than just different indications for certain pills, but like, how does it inform what we're doing in a novel era? So take us through that update.
So EMBARK has now been published for many years based on their initial MFS data. And we got an OS data from Steve Freeland here, concurrent NEJM publication, which is always nice to see, and a really impressive feat from the authorship group. EMBARK, just to remind everyone, is the use of enzalutamide either in combination with ADT or in monotherapy as compared to ADT in patients with hormone-sensitive, biochemically recurrent prostate cancer. This is non-metastatic based on conventional imaging. And so these patients, if you've had a radical prostatectomy, had to have a PSA over 1. If you had not, if you'd had primary radiotherapy, it had to be a PSA of 2 over nadir, and then negative conventional imaging. For what it's worth, the actual median PSAs are more around 5. So, in our clinics, these are relatively high risk, late biochemical recurrent disease. To add a little nuance to that high risk, the doubling times here had to be under 9 months, and many patients had doubling times under 3 months. And so, I think this is a truly enriched, high risk biochemically recurrent population. So as mentioned, patients were randomized enzalutamide plus ADT, enzalutamide monotherapy, or ADT alone. These data were first presented back at AUA 2023, I think, showing an MFS benefit. And today with this meeting, with the addition of about 2 years more follow-up, we see OS data. And I think this is, truly, really remarkable data, Steve. I think highlighted that the observed hazard ratio, which falls under 0.6, represents the largest relative benefit of the use of an ARPI in prostate cancer that's been observed in a phase 3 trial ever.
Yeah, it's amazing. And I think to come back to how we put a bow on this section is, what you and I talk about a lot. I'm sure wherever you live, this is coming up in tumor groups or in hallway conversations, but these patients who are so-called high risk, or let's say Stampede very high risk, or patients who have biochemical recurrence in current era can get PSMA PETs. I mean, we just can't ignore that this is happening. And so in these patients who are conventionally meeting these indications, but then have PSMA PET positivity, we oftentimes, apart from leveraging SBRT, wherever it might make sense, as you mentioned, we give systemic treatments. And I think one of the takeaways here is to say, I think we can circle back to saying there's a group of patients who we could certainly have fixed duration of therapy. Maybe it's 2 years, maybe it's being undetectable at 2 years, but clearly lifelong on novel imaging where they conventionally meet Stampede or BCR is probably over treatment.
Yeah, I think I totally agree. I think we've been spending maybe the last almost decade trying to intensify and add therapies, and we need to now think about how we can thoughtfully take therapies away without harming the OS benefits that we've observed from adding them. And I think it's important to emphasize that in the context of EMBARK, patients got about 9 months of therapy, and then assuming they'd had a good PSA response, they went on drug holiday and reinitiated their randomized treatment regime at predefined PSA thresholds. But for patients who got the ENZA plus ADT combo, on average, they were off drug for 18 months. So they got 9 months of drug, and then they were off drug for 18 months before the need to reinitiate. And some patients I know have never reinitiated. And so, I think this really offers us an opportunity to reduce the burden of treatment and the toxicity associated with treatment for these patients, balancing those, oncologic efficacy, survival outcomes against the toxicity that these drugs do carry. And I think, that offers us a way forward. And we have to be nuanced about how we apply data acquired without novel imaging into patients
Totally.
who have it. And I worry about undertreating, but I think this offers us the opportunity to maybe scale back a little bit as we move in that fine line between, high risk, non-metastatic and truly metastatic disease. And so in that setting, maybe we should go on to conventionally defined metastatic disease.
Yeah, no, and so I think a nice transition to MCSPC and a couple things here. Let's start maybe first with the Capitello 281 trial, and really this is a study looking at how to manage better patients with PTEN deficiency. So very briefly, if patients are PTEN proficient, their cancer is driven largely by AR signaling. But if you're PTEN deficient, that has an additional proliferative drive, you have poorer prognosis. And so capivasertib, or what I'll call CAPI, is a selective inhibitor of all three AKT isoforms, so AKT 1, 2, and 3. So this was a randomized double-blind phase 3 trial. So again, selecting de novo, MCSPC, all of whom were PTEN deficient, and that was using IHC, cytoplasm staining, and the cutoff was 90% or more. We can get to that. And essentially, you needed to screen 6,200 patients, which then led to a 1,000-patient trial, which got randomized to abipred and placebo, or abipred with a CAPI, which is given 400 BID of 4 days on, 3 days off. Ultimately, these were 500 patients in each arm, generally pretty well balanced. Largely bone disease, 5% or less having liver, and we'll talk about how that matters for other MCSPC trials we've seen. And then, the kind of high risk of 61% with high volume disease being the majority of these patients. So the quick readout is that rPFS was improved. I think kind of unsurprisingly, you've got a PTEN deficient group and you're giving a drug that presumably works in that setting. So a hazard ratio of rPFS of 0.81, probably a little bit under hitting what you'd like to see when you're just looking at rPFS, but nevertheless, this is an improvement of about 7.5 months. A lot of groups seem to kind of really benefit from that. Overall survival hazard ratio was 0.9, and it's still an interim, but many other endpoints that we think matter, like time to next treatment, look to favor a CAPI, but not everything has been statistically significant at this time. To me, I think this is a great first foray. There's lots to be said about this cutoff. So 90% or more, that's all randomized patients. But when you look at if you go 95%, 99%, or 100% on this cutoff for PTEN deficiency, I mean, the hazard ratios just get even more favorable towards drugs. So, is that a reasonable enough cutoff? I think seems like it, but certainly not surprising that you see better outcomes the more you go along. I mean, I think the side effects will need some careful monitoring, as you would with any of these kind of pills that are targeting certain pathways. I do think, to me, a big takeaway is that any of these patients who have these type of alterations, simply sitting on PSA to guide reimaging, as we often do with our so-called general patient, you might get an image at that first year at PSA nadir and then just follow PSAs. I think these patients, BRCA1, 2, other HRR alterations, probably need more routine imaging, just when you look at the progression that these patients can experience. But, I think that was a nice new add-on for, again, refining biomarker-driven approaches in MCSPC patients.
Yeah, absolutely. We're looking to do more than just our standard blanket treatment paradigm. We want to be able to personalize a bit towards selecting patients for agents that are specifically going to help them. I think we talked a lot already about lutetium PSMA to find disease, but we also can use lutetium PSMA as sort of a radiologic biomarker to try and select patients in a theranostic paradigm. And we saw some great presidential data from Scott Tagawa. You want to walk us through PSMAddition?
Yeah, I mean, this was, again, highly obviously publicized as a presidential press release earlier from the PSMAddition trial. Look, I think our listeners and viewers know, but we have lutetium PSMA 617 in a post-taxane setting per vision, so post-ARPI, post-chemo. there's the data in taxane naive PSMA4, which as of this recording is highly discussed around the world for HTA process and ultimate use. But now this was looking at saying, hey, let's add, so addition of lutetium in the MCSPC setting. So these were patients allowing up to ECOG2, needed one PSMA metastatic lesion or more on gallium-68 type of imaging. They were appropriate to get ADT and ARPI. So we're not going to talk about triplets here because chemo wasn't really used. The patients were randomized 1-to-1 to that control arm of ADT and ARPI versus having ADT, ARPI, and then lutetium in the classic kind of schedule of 7.4 gigabecquerels plus or minus 10%, 6 cycles every 6 weeks, and then RPFS, primary endpoint, and allowing crossover, and then having safety follow-up and OS. So, we got a second interim RPFS readout presented here. And, essentially what's interesting is that when you look at just the treatments people had at allocation, most patients were getting abiraterone. About a third were getting apalutamide, maybe just over a quarter were getting ENZARAD. Daryl wasn't super high used in this setting, just given the time trial was conducted. What was interesting here is, mostly good ECOG performance status, but the comments on visceral disease and, just the clarification of, PSMA picked up visceral disease versus what we'd seen in conventional imaging trials, was 40%. Bone being 9 out of 10 patients and soft tissue being around 60%. The PSA on entry was around 11 to 12, and 2/3 had, Gleason 8 or more and high tumor volume. And again, half of these patients were de novo. So blinded independent review, RPFS improved, hazard ratio of 0.72, medians not reached. So we have a totality of the curve suggesting that this is benefiting patients in a very large trial. All the point estimates in the forest plots, admittedly, we haven't even reached medians yet, look to be benefiting. The pre-specified ITT analysis for OS is still lots of censoring. There's crossover. And at this point, hazard ratio is 0.84. Responses seem to benefit the intervention, although patients with ADT and ARPI do pretty well. And then there's obviously the key to keep an eye on is the toxicities. I will say, some of these quality of life metrics, which we can say what we want about how perfectly they are done, either didn't show massive improvement or perhaps there looked to be some favoring of the ADT ARPI. So I think, look, this is a positive trial in the RPFS. This is MCSPC. We're used to seeing OS benefit. I think Arunazad did an excellent discussant on this. The Australians and other folks have been using PSMA PET for a long time. I think one of the takeaways was we just need to be a little careful about how quickly we go to this space. I think it's unquestionable that this treatment works for these patients, is active. But when you talk about globally making this the standard of care that all patients should be receiving for MCSPC as we intensify and then intensify on intensification, probably needs more follow-up. I think we've seen that either treatment that integrates chemotherapy or triplet approaches is still relevant. Treatment that might allow for lutetium to be accessed later as we get better and better with MCSPC treatment. So this was great data to see. I see it as a first pass. Probably not going to impact what we do kind of next week, next month. Mm-hmm. But it is showing that we are getting better with theranostics earlier.
Yeah, I think, to draw a little parallel to the comments you made around P10 staining in Capitello, I think there's really an opportunity here to better evaluate patient selection. Lutetium PSMA is a theranostic agent, and we can, I think, better align our PSMA PETs with our choice of intervention. And so here, single site of PSMA avid disease was enough for enrollment. Their screen out rate was very low. And when you think of other trials, things like therapy that were very selective in terms of excluding patients with PSMA and FDG discordant disease, I think we can be a little smarter maybe in our use of PSMA PET in how to pick patients who are really going to benefit from the use of lutetium here. Even just things like SUV mean, SUV max. We really want to think that you want PSMA avid sites of disease that are going to respond well to lutetium as compared to less avid disease is probably going to get less bang for their buck. And And when we think about, toxicity trade-offs, really getting that maximum bang for our buck, because we have to remember that in this trial, to their credit, they have a very good, very active control arm. And we're trying to improve on something that is still the standard of care. And to be honest with you, in the community, a standard of care we're still striving to reach in some cases. And so
Totally.
we want to get better, but we need to do it, I think, in a little bit of a thoughtful way. And to me, this data doesn't say that 84% of MCSPC patients should be getting lutetium, but we can, probably do a more thoughtful job of defining a subset of MCSPC where lutetium could offer a really good clinical benefit. And I think, when we have those other treatment options, you alluded to chemo as a triplet in MCSPC. Anytime you have that alternative treatment option, you have to be careful that you're picking the right patient. And maybe in that context, we should think about moving the next step down into MCRPC, ARPI pre-treated, PR21 data from Kim Chi, comparing that upfront lutetium followed by dosi versus upfront dosi followed by lutetium. You want to walk us through PR21?
Yeah, I mean, run by the Canadian Cancer Trials Group, so the PR21 trial. So again, kudos to everyone kind of who came together to pull this off and recruit patients to, I think, what was really an exciting design. So, knowing that, already established that lutetium works in a, post-taxane setting, this trial was an open-label randomized phase 2 with a built-in crossover. So patients who were chemo-naive, had a prior ARPI, PSMA PET positive, was uptake greater than liver, excluded if 50% or more of extraosseous lesions or greater than 5 centimeters of soft tissue, and all the requirements you need to be eligible, with an ECOG up to 2, got randomized to getting dosi, 75 milligram per meter squared up to 12 cycles, or the 6 cycles that we've previously discussed of lutetium, and then on progression, randomizing to the other arm. So you have an RPFS1 and then theoretically an RPFS2. And so, what they were able to find, and they had a really nice concert diagram of showing who got what and then kind of when. I think the real takeaway is that pretty balanced between, both groups overall. About 14% of patients having prior dosi for MCSPC. So that's the difference, right? We're able to kind of understand that. Looking at some SUV data, which was interesting, but what they found is that the RPFS in the ITT of starting with lutetium, just under 9 months, starting with docetaxel was just under 11 months. So 8.6 versus 10.7, has a ratio of 1.01. Forest plots, as you can imagine, largely around unity. Median SUV mean, which again isn't routinely reported in all of our routine clinical practice PSMA PET reports, was prognostic but was not predictive. Really, when you looked at, you'd think if something was more tolerable and more efficacious, how would that impact the quality of life? The fact P total score looked pretty similar in terms of time to deterioration, has a ratio of 0.93, very expected adverse event profile, and lab abnormalities we're looking at. And so then the RPFS2 became, going from lutetium to docetaxel, median was 13 months, but if we went from docetaxel to lutetium, that was 15.8. Now that hazard ratio is 1.4, p-value 0.09, but not surprisingly then, if you're seeing RPFS 1 and 2 look like that, overall survival, which in MCRPC, for new drug interventions, we've largely seen a 4-month benefit over respective standards, which have varied in all the trials for their control arms. But lutetium to dosi, 14.3 months, dosi to lutetium, 18.2, again, not significantly different. But, certainly showing that some secondary endpoints might have favored lutetium, but at the end of the day, there was no difference in the primary endpoint. And, there'll be some more analysis to come. But it's a really important readout because we have so many registration industry-driven trials to show when you can use a drug, but exactly the question we have in clinic, which is, let's assume post-ARPI a treatment were available. How should you do that? So I don't think we have enough information to say all these patients should definitely be getting lutetium next in all settings, although this is a population that was randomized and could get docetaxel up front. So not every post-ARPI progressor is going to be eligible or appropriate for chemo. So that's where there's that difference still. But here, that sequence didn't seem to point one way or the other.
Yeah, I think it's interesting to look at that concert diagram you alluded to in the the number of patients that actually did cross over and got their second line of therapy, because I think it's really notable when we're trying to interpret these data that, in the context of patients originally allocated to lutetium in the ITT population, that's 100 patients, only 38 crossed over to docetaxel, whereas conversely, if you started off allocated to docetaxel, ITT of 99 patients, 56 crossed over. And so, the ability and or patient interest of going to that second line drug in this trial, which is probably their third drug for metastatic prostate cancer, the lutetium first sequence seemed to get, fewer patients onto their third line. Whereas if you went docetaxel first, lutetium as your third line, you got more patients on that drug. And so I think that's one of the things we're going to have to try and understand as we try and interpret the OS and RPFS2 results.
100%. I mean, this whole approach of having lots of tools in the toolbox, I think, most people who do clinical trials or want to treat patients, I mean, we want access. But these trials are so important because now it says which tool when. And I think it's hard to do randomized studies in every sequence scenario. But I think it shows, listen, taxane-based chemotherapy is active. We've had the CARD data for some time that said if you progress very quickly within 12 months of your ARPI, probably your subsequent line would be better to have cabazitaxel than at that point an ARPI switch. So we've always been trying to ask this question, and I again, congratulate them for doing so. Unsurprisingly, that group will have biomarker work like ctDNA to look at. So maybe we'll try and understand more, because I am curious about ctDNA and PSMA PET. It's not necessarily concordant in all these trials. So will that be able to just give us a hint of why and who would respond better first with what treatment?
Absolutely.
I mean, look, we're again, it's such a packed ESMO. I feel like every podcast we're up against time, but maybe some potpourri. Chris, anything you were excited about? I mean, from the MCSPC setting, we previously heard about Amplitude. We've got some patient-reported outcomes. Top line takeaway.
Yeah, I mean, I think in MCSPC, we're talking about trying to select patients better, right? We're talking about PTEN abnormalities. We're talking about using lutetium PSMA, using PSMA PET to guide us. So, at ASCO, we saw HRR as our predictor, and Amplitude showed us an RPFS benefit to adding a niraparib to an ADT and AbbVie backbone. Here we saw some patient-reported outcome data. I have to tell you that in general, I find that our tools are probably the biggest issue here. It's not a study design question. It's not an intervention problem. It's our tools are not great, but I think it's reassuring to see that the use of niraparib doesn't really harm patient-reported outcomes, and so patients are able to tolerate this regime. And I think that's important for us moving forward as we think about trying to integrate the PARP inhibitors a little bit earlier in our disease phase. I think as we talk about intensification, we talk a lot about systemic therapy, and so I don't want to forget the other way we can intensify. So in MCSPC, we've had some data around the use of local prostate-directed radiotherapy as a way to intensify, and that's the original triplet maybe would have been ADT, ARPI, prostate RADs. We could think about like quads, adding in the radiotherapy. And so we saw a nice contribution from the StopCap group. This is, an individual patient data meta-analysis looking at the role of radiotherapy in MCSPC patients. So really this is, informed by HORAD, STAMPEDE, and then the PEACE-1 data. There's been a little bit of discordance between those trials, particularly in the context of PEACE-1, not showing the OS benefit in the lower risk, the lower volume patient population. Here, I think the general takeaway for me is that prostate radiation does still benefit a subgroup of patients. There is an overall marginally significant OS benefit. And really, if we go down to PFS, we see a greater benefit, but volume status still does matter. Now, any meta-analysis is driven by the data put in it. And if you look here, with weighting, STAMPEDE gets the most weight in this meta-analysis. So not shockingly, the STAMPEDE conclusion is the one that the aggregate data comes to. But I do think that these data reinforce the role of rad-onc consultation and local primary radiotherapy in many patients with MCSPC. And so while we focus on doing a better job systemically, we can't forget about the value of radiating, and we need to think about both the prostate and in perhaps a more experimental context, also radiating the metastases.
Yeah, I mean, untreated primary and GU cancers in general, but especially in prostate, I think the volume status has helped us. Maybe the higher volume patients could have, either preventative or, on deck circle, so to speak, radiation for preventing later GU kind of side effects pending response to these systemic treatments that are getting better and better. So what a whirlwind. That's prostate cancer covered. Thank you to our listeners and viewers. For Chris Wallis, I'm Aly-Khan Lalani. Don't forget to listen to our other podcasts on bladder cancer and kidney cancer. We'll be back for more.